For decades, I mean, pretty much since modern anatomy began, medical textbooks confidently mapped out this very distinct, very important muscle controlling the female urethra.
Right. It was standard anatomy.
Yeah, taught in medical schools all over the world.
Yeah.
But recently, researchers went back,
Hmm.
did some highly meticulous cadaver dissections, and discovered something just absolutely shocking.
That the muscle doesn't actually exist at all.
Exactly. We completely hallucinated a piece of human anatomy. And, in doing so, we've fundamentally misunderstood how the anterior vaginal wall actually supports itself.
It is a phenomenal example of medical momentum. Because once something is in a textbook, I mean, it takes a mountain of evidence to get it out.
Oh, for sure.
We are now realizing that the anatomical support system in that specific region is, well, it's far more complex, dynamic, and honestly far more vulnerable to collapse than we ever thought.
And when that complex system does collapse, which is what we are digging into today, the way we fix it sounds like pure science fiction.
It really does.
So we want to welcome you to another deep dive. Today's mission is to uncover a pretty fascinating biological mystery.
Yeah, we are looking at how injecting a specific high-viscosity formulation of hyaluronic acid, or HA, into female intimate tissues physically commands the body to rebuild its own cellular architecture.
Right. Specifically, we are going to look at the physiological mechanisms that cause this HA to stimulate secondary endogenous collagen deposition.
Which is incredibly relevant for areas around the anterior vaginal wall, like the area frequently targeted in procedures like G-spot augmentation.
To map all this out, we are pulling from a really diverse stack of sources for you today. We've got the anatomical texts detailing those corrective cadaver studies.
We also have some incredible clinical data on vulvovaginal atrophy and labia majora augmentation.
Yeah, including that major study from BMC Women's Health.
Right, and finally, we'll get into some dense, cutting-edge biomechanical research on extracellular matrix stiffness and cellular mechanotransduction.
Okay, let's unpack this.
Yeah.
Because anyone who follows aesthetics, they know HA is a facial filler.
A volume thing, yeah.
Right. But our sources are painting a wildly different picture here. This isn't just about taking up space. It is about using mechanical force to literally hack local DNA.
Which is mind-blowing.
Totally. But before we get into the cellular mechanics, we need to talk about that missing muscle. Like, how did we get the anatomy of the anterior vaginal wall so wrong in the first place?
Well, it mostly comes down to how historical dissections were actually performed.
Okay.
In the past, anatomists relied heavily on formalin-fixed tissue, and that harsh chemical process shrinks and distorts the really delicate structures.
So they were looking at damaged goods, essentially.
Basically, yeah. They assumed the female urethra, which is only about, 4 centimeters long, had a dedicated striated urogenital sphincter wrapping around it.
Kind of like a rubber band keeping a hose pinched shut.
Exactly. But when modern researchers utilized unembalmed, fresh frozen cadavers, along with advanced 3D histological staining, they couldn't find a distinct sphincter anywhere.
Wait, really? So there's just no rubber band?
No rubber band.
Then how is the urethra structurally supported, considering it's embedded right there into the anterior vaginal wall?
It is actually supported by this incredibly intricate network. The tension comes directly from extensions of the levator ani, which is a massive pelvic floor muscle.
Oh, I see. Rather than a localized sphincter.
Right. But even more surprisingly, over 50% of the volume of the anterior and lateral urethral walls is made up of a rich umbrella of cavernous vascular tissue.
Hang on, cavernous vascular tissue meaning like erectile tissue.
Yes. It primarily originates from the bulb of the vestibule, which is a major part of the internal clitoral network.
Wow.
So instead of a simple tube clamped by a muscle, you have this dynamic, highly vascularized hammock.
A hammock. Okay, that makes sense.
And it is packed with erectile tissue and suspended by the broader pelvic floor. And the entire matrix holding all of this together, the vaginal mucosa, the connective tissue, it's exquisitely sensitive to estrogen.
Which brings in the systemic vulnerability, right? We know estrogen maintains tissue elasticity, but what is it actually doing at the chemical level to that specific hammock?
So estrogen actively maintains the local acid mucopolysaccharides.
What now?
Basically, they are complex, slimy sugar molecules that act as the structural mortar of your extracellular matrix.
Ah, okay. The mortar holding the bricks.
Exactly. They keep the microenvironment hydrated and thick. Estrogen also maintains the naturally occurring hyaluronic acid within the tissue.
Got it.
So when a woman experiences a severe drop in estrogen, whether that's from menopause, premature ovarian failure, or maybe certain cancer treatments, That mortar just degrades.
And that leads to vulvovaginal atrophy or vaginal laxity.
Yes.
The sources note that without that structural mortar, the mucosa physically thins out. The vascular network shrinks, which leads to profound dryness and dyspareunia or, pain during intercourse.
Because the structural collagen just unwinds. The hammock essentially loses all of its tension. It just sags.
Right. And historically, medicine hasn't had great structural solutions for this beyond localized estrogen therapy.
Which doesn't always rebuild the lost architecture, especially in the more severe cases.
Right.
Yeah.
And this is where the modern interventions come in, utilizing high viscosity, specifically cross-linked HA, injected directly into the anterior vaginal mucosa or the labia majora.
Exactly.
Now, I want to pause here because we all know the baseline properties of cross-linked HA.
Sure.
We know the cross-linking prevents the body from breaking it down immediately, making it a highly viscous gel. But if the problem is a collapsed atrophic hammock, how does injecting a thick gel actually fix the structural integrity?
It seems counterintuitive, right?
Yeah. I mean, I always thought of it as just a biological sponge, like it absorbs water and puffs up the tissue.
Well, what's fascinating here is that the sponge concept is a massive understatement of the physics involved.
Oh, really?
Yeah. It is much more aggressive than that. It comes down to the fundamental chemistry of high molecular weight HA.
Okay, lay it on me.
HA is a polymer made of repeating disaccharide subunits, and these subunits are packed with incredibly dense negative electrical charges.
So it's like injecting a chain of powerful molecular magnets into the tissue.
That is actually a brilliant way to look at it. Because of those dense negative charges, the absolute moment it is injected, it violently attracts positive ions from the surrounding biological fluid.
Specifically sodium, right?
Yes, specifically sodium. You get this massive localized rush of sodium ions flooding directly into the HA matrix.
Wow.
This creates a severe electrochemical gradient, which biophysicists call a Donin effect.
The Donin effect. Okay.
Right.
So because you suddenly have this huge hyperconcentration of positive sodium ions in one localized spot, the body's natural response is to flush the area with water to dilute it.
Correct. It creates an immense osmotic swelling pressure.
But wait, remember, the HA is cross-linked.
Exactly. It is chemically tied together into a dense lattice. So when the water rushes in, the HA doesn't just dissolve and float away.
It's trapped.
Yes. It forcefully swells, and because it is trapped within the tissue planes, it pushes outward with incredible mechanical force. It acts almost exactly like a hydraulic jack.
A hydraulic jack. Wow, okay, that makes so much sense.
Right.
So instead of just passively taking up space and looking plump, the Donin effect generates hydraulic pressure that artificially retensions the tissue.
It violently pulls the hammock taut again.
It physically straightens and stretches those collapsed, aged collagen fibers in the patient's extracellular matrix.
You've got it.
Here's where it gets really interesting, though. We have a hydraulic jack artificially holding the wall up. But the clinical data from the BMC Women's Health Study shows that months after the HA should have started degrading, the tissue is still thick.
Yes, the clinical benefits persist.
The patients still have reduced dyspareunia. So how does that physical hydraulic tension translate into the creation of new secondary collagen?
That is the Mector transduction engine.
Oh.
And it completely relies on how fibroblasts behave. Since our audience probably already knows fibroblasts are the cellular factories that manufacture collagen, we can skip the absolute basics and look at their anomalous behavior here.
Perfect.
Fibroblasts don't just sit there blindly waiting for chemical hormones to tell them what to do. They constantly probe the physical stiffness of the extracellular matrix around them.
So they're actively feeling the tension of the hammock.
Actively.
But how do they actually do that without a nervous system?
They use specialized transmembrane receptors, specifically integrins and CD44 receptors.
Okay, integrins and CD44.
They act as mechanosensors. You can think of them as the cell's little hands, firmly gripping the collagen fibers outside the cell.
Oh, I see.
When the HA creates that hydraulic pressure and physically stretches the old collagen, those collagen fibers physically yank on the integrins.
So the cell is literally being stretched.
Yes, the membrane is pulled. And that physical stretching of the integrin initiates a chemical to physical conversion.
A mechanical force turning into a chemical signal.
Exactly. It triggers some incredibly complex mechanotransduction pathways inside the cell. The primary driver identified in the research is the integrin FAK-YAPTAZ pathway, alongside the ROTEC pathway.
Hold on, you just threw a whole bowl of alphabet soup at me. FAK-YAPTAZ-RCK.
I know, it's a lot of acronyms.
let's not gloss over the mechanism here because this is the core of it. What are these pathways actually doing inside the fibroblast when the integrin gets yanked?
Let's just follow the dominoes. When the integrin is physically pulled by the stiffened matrix, it activates FAK, which stands for focal adhesion kinase.
And a kinase is just an enzyme that acts as an on or off switch for other proteins, right?
Spot on. FAK is an enzyme that phosphorylates or switches on a cascade of other signaling molecules deep within the cytoplasm.
Okay.
The most important targets in this whole cascade are YAP and TAZ.
YAP and TAZ.
Got it. Now, in a relaxed, soft, atrophic environment like a postmenopausal vaginal wall, YAP and TAZ are highly unstable.
Meaning they don't last long.
Right. They just float around in the cell fluid, they get phosphorated in the wrong way, and they are quickly degraded and recycled. They never do anything.
Because there's no physical tension to keep them active and useful?
Exactly. But when FAK is switched on by high mechanical tension, it alters the signaling cascade so that YAP and TAZ are no longer degraded.
Oh, wow.
Instead, they are transported directly through the nuclear pores and into the cell nucleus where the DNA is actually stored.
So they act as literal mechanical messengers. The outside of the cell gets pulled, and YAP and TAZ get shoved into the DNA vault.
Yes. And once they are inside the nucleus, YAP and TAZ physically bind to transcription factors on the DNA.
They flip the genetic switches.
They initiate what we call transcriptomic reprogramming. They force the DNA to upregulate specific collagen synthesis genes.
Which genes exactly?
The biomechanical sources point out that this mechanical stress specifically hyperactivates the genes COL1A1, COL3A1, and KL3A1.
COL1A1 and COL3A1.
Wait, those are the genes responsible for churning out type I and type 3 collagen, right?
The structural heavyweights.
They are the building blocks. So by injecting this rigid, high-viscosity HA, you are mechanically forcing the fibroblast's DNA to start pumping out new endogenous collagen.
That is the secondary collagen deposition we were talking about.
Exactly. You are tricking the cells into building new tissue because they genuinely believe they are in a high-tension, youthful environment.
And it doesn't just stop at pumping out the raw material, does it? Because once the fibroblast secretes those new collagen molecules into the extracellular space, the sources mention another enzyme comes into play.
Yes, lysyl oxidase, or LOX.
Right.
The same mechanical tension that upregulates the collagen genes also upregulates these LOX enzymes.
And what do?
They act like biological welders. They cross-link the newly minted collagen fibers together, locking them into a rigid, durable network.
So let me get this straight. The HA filler provides the temporary hydraulic jack.
Yes.
The fibroblasts feel the pressure and manufacture the bricks. And the LOX enzymes weld the bricks together, all before the jack is eventually dismantled by the body months later.
If we connect this to the bigger picture, it means the procedure isn't just masking vaginal laxity. It is utilizing physics to mandate a biological reset.
That is incredible.
If you look at the methodology of the BMC Women's Health Study regarding deserial injections, they actually took histological biopsies of the tissue before and after the treatments.
Right, they didn't just ask the patients if they felt better on a survey. They looked at the actual tissue under a microscope.
They absolutely did. And the biopsies showed a massive, measurable increase in the density of the collagen fiber network.
Proof of the mechanotransduction.
Exactly. Along with a significant thickening of the epithelial layer. The architecture of the vaginal mucosa and the labia majora was physically restored.
Which directly correlated with the patients reporting long-lasting hydration and a severe reduction in dyspareunia, right?
Yes, for up to 12 months.
It's a completely elegant system. But, it raises a huge question about the intervention itself. Well, if mechanical tension is the sole trigger for this cascade, couldn't a clinician just inject, I don't know, any dense material? Like, does it have to be a specific type of HA? Does the molecular weight of the HA actually matter, or is it just about creating pressure?
Oh, the molecular weight is arguably the most critical variable in the entire procedure.
Really?
Yes. It dictates the exact biological response, and getting it wrong can cause immense harm.
Okay, explain that.
In the field of mechanotransduction, we broadly divide HA into two categories. You have high molecular weight HA, which is anything over 500 kilodaltons,
Okay.
and low molecular weight HA, which is under 500 kilodaltons.
And earlier we were talking about high molecular weight HA being the one with the massive chains that tangle up and create the Donan effect, right?
Yes. High molecular weight HA is the structural component. It provides that immense osmotic swelling and matrix stiffness.
So it runs the YAP and TAZ engine.
Exactly. It promotes cellular homeostasis. But Crucially, the body recognizes these massive intact chains as a sign that the tissue is healthy and uninjured. Therefore, high molecular weight HA acts as a natural anti-inflammatory and an immunosuppressant. It basically tells the immune system, hey, everything is fine here, do not attack.
Okay, so that's the calm, sturdy scaffolding. But what happens if a clinician injects low molecular weight HA instead?
Low molecular weight HA behaves entirely differently. You really have to look at it from an evolutionary perspective.
How so?
In nature, when you suffer a severe trauma, say you get a deep laceration, the natural high molecular weight HA present in your tissue gets violently chopped up
By the injury.
by reactive oxygen species and enzymes. Yeah, it gets chopped into tiny fragments.
Oh, so tiny HA fragments are a biological signature of tissue damage.
Exactly. The body has evolved to recognize low molecular weight HA as a DAMP,
A damp.
a danger-associated molecular pattern. When the immune cells detect those short HA fragments, the fragments physically bind to toll-like receptors on the cell surface.
Toll-like receptors. Wait, those are basically the cellular smoke detectors, right?
They are the early warning system. When low molecular weight HA trips those smoke detectors, it triggers massive pro-inflammatory pathways.
Oh boy.
The fragments basically scream at the body, "We are damaged! Send inflammatory cytokines! Start angiogenesis to build emergency blood vessels!"
No, I mean, that sounds great if you actually have an acute wound that needs to heal rapidly.
Right.
But if a clinician injects a high concentration of lightweight HA fragments into healthy, albeit atrophic, vaginal tissue,
You trigger a chronic runaway inflammatory response.
the tissue thinks it's constantly wounded.
Exactly. You get severe swelling, redness, and long-term irritation completely without the structural stability needed for the YAP and TAZ mechanotransduction pathway to work.
Because the fibroblast won't lay down healthy, neat collagen in a war zone.
Never.
Wow. To synthesize this, it's a super delicate balancing act.
Mm.
You want the deep structural tension of the heavy molecules to calmly tell the fibroblasts to lay down permanent collagen.
Yeah.
But if the chains are too short, you just hit the panic button. So how do modern vulvovaginal fillers like Deserial manage this? Do they just exclusively use the massive chains?
Well, this raises an important question for biomedical engineering because, strangely enough, you actually want a tiny, controlled bit of the regenerative blood vessel stimulating properties of the lighter molecules.
To restore blood flow to the atrophic tissue, right?
Exactly. But you absolutely cannot cause chronic inflammation. This is why the advanced treatments utilize specific cross-linking technologies,
Like what?
what the literature calls hybrid cooperative complexes, or HCC.
Oh, so they engineer a specific ratio of the two.
Yes, they thermally stabilize and carefully combine high and low molecular weight chains, or they use highly specific PEG cross-linking.
What does that achieve practically?
They create a matrix that provides that immense structural stiffness required to yank on the integrins and run the mechanotransduction engine.
Hydraulic jack.
Right, while very, very slowly releasing just enough low-weight fragments to mildly stimulate tissue regeneration.
Ah, without tripping the toll-like receptors into a full meltdown.
Exactly.
It is a highly engineered Goldilocks zone. And when clinicians hit that zone, whether they are augmenting the labia majora for aesthetic and functional reasons, or injecting the anterior vaginal wall to treat urogenital atrophy.
The result is that the fibroblasts feel the tension, they read it as a signal to work, and they rebuild the extracellular matrix from the inside out.
The clinical efficacy relies entirely on that mechanotransduction engine running smoothly.
Yes, you are taking a tissue that has chemically collapsed due to estrogen loss, and you are physically forcing it back into a youthful, highly active state.
So what does this all mean for you, the listener? I mean, it means we need to completely reframe how we view these treatments.
Absolutely.
HA injections into the vulvovaginal area aren't just cosmetic plumping. It is a sophisticated biohack. By altering the physical stiffness of the extracellular matrix with a carefully engineered electrochemical gradient, we are mechanically forcing our own DNA to start pumping out secondary endogenous collagen.
It really forces us to completely rethink how healing and cellular function work across the board.
Yeah, how so?
We are so heavily conditioned by modern medicine to view the body purely as a chemistry set. You know, you have a symptom, you take a pill, the chemical binds to a receptor, and the symptom goes away.
Right, chemistry first.
We view the structural matrix of our bodies just as the inert scaffolding that holds the chemistry set together.
But this deep dive proves that the scaffolding itself is giving orders.
Yes.
Our cells are constantly feeling their physical environment to decide how to behave. The YAP and TAZ pathways show us that our cells are just as sensitive to mechanical tension and hydraulic pressure as they are to systemic hormones like estrogen.
The physical state of the extracellular matrix is an independent variable governing nuclear transcriptional activity. It's not just a side effect of aging.
The loss of tension is the main driver of further cellular decay.
Ex-
And that leads to a really profound final thought for you to ponder today. If our cells' behavior, and even the aging process itself, are largely dictated by the mechanical stiffness of their microscopic environment,
mm-hmm.
what other chronic age-related diseases are actually just mechanical failures at the cellular level?
It's a huge question.
Right. And have we been trying to treat them for decades with the wrong chemical tools when what they really needed was a mechanical reset? Sometimes the cure isn't a new chemical. Sometimes the cure is just the right kind of physical tension, telling the wall to build itself.